thank you for having me here at Classificon. I've heard good reports about this conference, so it's really my absolute pleasure to be here and to tell you all about ICD-11 in the Netherlands. So my name is Koen van Gol. I'm with the National Institute for Public Health and the Environment in the Netherlands. It's called RIVM. And at our institute, we also host a WHO Family of International Classifications Collaborating Center, just like Miroslav and his team are doing here in Prague. And we also participate in the HUVIC network, of course. So this is an outline of what I want to discuss with you. Firstly, I would like to briefly sketch out the Dutch healthcare system for you. Then I would like to tell you a little bit about the current use of the WHO classifications in the Netherlands. And then I would like to come to the ICD-11 and tell you all about our plans for ICD-11. And finally, some national and international developments that may interfere with our ICD-11 plans. So the Netherlands, it's a country in the northwestern part of Europe, to the left side of Germany and just above Belgium. It's about half the size of the Czech Republic, but it has almost the double amount of inhabitants. It's around 18 million. In the Netherlands, we have 8 university medical centers and about 100 general hospitals, and about 150 outpatient clinics. We have an aging population. About 20% of our population is 65 years of age or older, and I think that's kind of similar here in the Czech Republic. But that percentage is growing in the future. We have a mandatory basic health insurance, and with that we have an independent healthcare institute that determines what kind of healthcare is insured. And we have an independent healthcare authority that determines the maximum prices for the treatments of healthcare. So, as for the current use of the WHO classifications, of course, the first use case is mortality. So when a person dies in the Netherlands, there's a coroner or a treating physician or a GP who will come and fill out the death certificate. A copy of that death certificate will then go to the civil registration, and another part of that certificate will go to Statistics Netherlands. On that certificate, there's a sequence of events that led to the death of that person, and the medical coders at Statistics Netherlands, they will transform that sequence into an ICD-10 code stating the underlying cause of death. Now, in here you see the leading causes of death for women and for men, being dementia for women and COVID-19 for men, and that was in the year 2021. We also use ICD-10 in the hospital, of course, the morbidity use case. That code, that ICD code is required by the pricing authority to have a good estimation of what the money that is going to healthcare is spent on what medical diagnosis. And on the right-hand side, you see that in the year 2019, dementia was the leading cause of healthcare expenditure, adding up to more than 10 billion euros. And the costs for intellectual disability came in as a second at almost 10 billion euros. Of course, we have all other sources as well for hospital data. We have the hospital discharge registries, but they also have a mandatory ICD-10 code, but as not every contact between the patient and a hospital leads to an admission. The hospital discharge registries are often an underestimation of the true prevalence and incidence. We have other information standards in use in the Netherlands as well. In the long-term care and the rehabilitation care, we use ICF, not so much for billing or statistical reporting. We use ICF more for clinical reasoning. In general practice, we use ICPC. It's the International Classification of Primary Care. And in mental health care, we use DSM-5. Actually, we use now DSM-5 TR, as was discussed this morning. But these are not the only semantic standards that are used in the Netherlands. We also use SNOMED, for example. In hospitals, there's this diagnosis thesaurus in use, which is an interface terminology or a user interface with SNOMED linkages and ICD-10 linkages behind it. So coming back to the ICD-10 and also referring to the discussions earlier today about the clinical coding and coding uniformity. In the Netherlands, we have medical coders who check and adjust or complement whatever the medical specialist fills in the electronic health record. And they also prepare the billing by the reimbursement by the health insurance company. And they also codify the discharge letter into ICD-10 codes. So they work on morbidity coding. At the same time, there's also coding going on in the Statistics Netherlands. So they work on mortality coding. Whenever there are questions about coding or coding difficulties, the coders in the hospitals can reach out to the DHD service desk. DHD stands for Dutch Hospital Data. And we have a structure in place in the Netherlands where we collaborate on coding issues between the ICD-10 expert group, the DHD service desk, and we at RIVM. And we give quarterly, quarterly coding advice to discuss and advise on how to tackle coding problems. And as you can imagine, that's very beneficial for the uniformity of the way coding is happening in the Netherlands. So you can say that this is the coding heart of the Netherlands. Now I come to the ICD-11. So our Ministry of Health has given the green light for us to start on the ICD-11 transition. And we foresee three major parts of work on the ICD-11: the translation, the education, and the implementation. And I'll discuss each of these elements a little bit more. So for the translation, we've broken down the amount of work into three parts, and also in a stepwise approach, doing the reference guide, then the user interface, and the foundation component. So it's a 3-by-3 approach, basically. And we distinguish between an initial translation and we think that on that initial translation you could use experts to verify that translation, and then the actual users of the classification can do the validation. So that's how we will approach the translation of ICD-11. And as a matter of fact, we are already doing the translation of the reference guide. At least we're not doing it ourselves. We outsourced it to a translation agency, and we hope to have the result by the end of 2023. And then the expert group of ICD-10, and together with Statistics Netherlands, will do the verification of the reference guide's initial translation. And then we will do a validation by pilot using the reference guide. As for the interface terms, which are the texts in all of the clickable buttons of the different websites, we are planning to have them initially translated by AI, by using AI, and do the verification ourselves, and then have that validated by NICTIS, which is an e-health agency in the Netherlands. And then as for the biggest chunk of work, the foundation component, we are planning to have it, to have an initial translation AI assisted, because we want to use all the existing translations that are already there to inform our translation. And then you can think of the existing translations of ICD-10, for example, but also SNOMED or Orphanet or other existing translations. So the verification of that foundation component will be done by the clinical coding community and also by the ICD-10 expert group. And more or less the same as in as Miroslav explained, we want to have the validation of the foundation component done by using an internet consultation, so that all stakeholders in the Netherlands can give their feedback. And we expect all of this to be finalized at the early stages of 2027. Now, as for education, we haven't planned it as carefully as Islam yet, but we would like to use the materials that is supplied by WHO, the WHO Academy e-learning. Of course, that needs to be translated as well. And from the previous transition from ICD-9 to ICD-10, we learned that medical coders were especially keen on a transition course, just an explanation of what is different in the new version compared to the old version. And we had that also tailor-made with the effect the transition had on healthcare insurance rules or other national specific rules. So we hope that we can do something similar again. And of course, we need to inform and train our software partners. So we're planning a series of webinars and developing a vendor package. And then as for the implementation, we have left the most difficult bit for our Ministry of Health. For now, they are in charge of sorting out what needs to be done before implementation can take place. And with that, I mean, there are things that need to be changed in the law. There are things that need to be changed in the rules of the Healthcare Authority and the Healthcare Institute. So that's really for them to decide. And they are now in the stage of putting out requests for service for an implementation advice. So they want to, they're seeking advice on how the implementation should look like. And also they are seeking advice on how the different stakeholders need to be involved. And that is quite a challenge, and because of that, we foresee that the morbidity use case will transition to ICD-11 later than the mortality use case, which seems a little bit more straightforward. And hopefully we will have that implementation advice by the end of 2024. As I said in the beginning, there are also some national and international developments that might hinder the transitioning to ICD-11 or affect. It's not just hindering, but it has some good effects and some bad effects. Some good effects is that now in the Netherlands there's a law on mandatory digital exchange of health information. So no more faxes, no more flash drives, no more CD-ROMs. Everything needs to be securely sent and safely sent. And of course, ICD-11's new all-digital makeup suits that approach very well. And we also see that with that new law, there's also a focus towards standardization of healthcare information and a trend toward standardization at the source and certification. And there's also even a shift noticeable towards working more open source and using open source software. And this, of course, has to do with the vendor lock-in situation that, that some hospitals in the Netherlands are in, where electronic health record companies are asking a lot of money for small adaptations in local applications of their product. Another consequence of the new law is that there's a renewed attention for the secondary use of health information. So reusing clinical information for purposes that they were not originally collected for. But that also needs some rethinking of how this clinical information can best be collected at the source so that its reuse can be optimized. And that's happening with the so-called health and care information models. Clinical building blocks is a synonym for that. Some international developments that may interfere. Of course, as discussed this morning already, the European Health Data Space and all of its elements, like the Digital Health Authority that needs to monitor the development of My Health at EU. And as I said, the reuse of health information that is governed by the Health Data Access Body and at the Health Data at EU element. We are not sure how this will take form yet and what standards or what semantic standards there will be mandatory in the EHDS. So this all can influence the decision to or when to transition to ICD-11. And when I said that the mortality use case will shift to ICD-11 first, I say that with a bit of a, how do you say, a caution, because Statistics Netherlands is part of the IRIS user group. The IRIS is a software tool for automated coding of causes of death. And it may very well be that there's a decision of this IRIS group, consisting of all kinds of countries, to transition at once as a block into ICD-11. But we don't know yet. And in principle, we do the Dutch translation of ICD-11 for the entire Dutch language area. And this also comprises some overseas territories and where Dutch is still the dominant language. And these may be suited for seed implementations of ICD 11. Suriname, for example, which is in Latin America, South America, has shown interest for transitioning ICD 11, implementing ICD 11 as soon as possible. But for that, they will need a Dutch translation first. So these are interesting developments that may have an effect on the decision of when we will implement ICD 11 in the Netherlands. Thank you very much.